Vaishnavi. Yeah, my friend from in med school. Actually, she and I ended up going in residency together. That was her name. Longest time she was about Vaish. She was like, no, it's Vaishnavi. And so I was like, why didn't you just tell us from the beginning?
You ready? It's unmute.
I am unmuted.
Okay, great.
Okay. Good morning, everyone. Thank you so much for joining our cardiology grand rounds today. My name is Vaishnavi Gadla, and I'm one of the chief cardiology fellows at PCU. It is my distinct honor to introduce Dr. Franck Azobou Tonleu today. Today's grand rounds are a part of Natalie and Jack Congdon Cardiology Lecture Series. In 2010, Natalie and Jack Congdon established the Natalie and Jack Congdon Visiting Scholars in Cardiology, which enables the Pauley Heart Center to attract a number of talented cardiologists and physicians. Jack Congdon was a student of the Augusta Military Academy and a graduate of Thomas Jefferson High School. After his service in the Army, Jack helped build the family trucking business of Old Dominion Freight Line and Old Dominion Truck Leasing. Jack's wife of 57 years, Natalie Congdon, graduated from Thomas Jefferson High School and attended Hollins College. Both Jackie and Natalie passed away in about 10 years ago. They have 3 children, Susan, John, and Jeff, who continue to support the Pauley Heart Center, with their son, John, serving as a donor and advisory board member. Now to our speaker, Dr. Azobou. He's originally from Cameroon in Central Africa and moved to the US during high school in Baltimore, Maryland. He completed his undergraduate studies at the University of North Carolina, where he studied biology and history, followed by medical school at the University of Virginia. He completed his internal medicine training at Emory University and is currently serving as a chief cardiology fellow at UT's Southwestern Medical Center. His interests include prevention, quality improvement projects, medical education, and pipeline programs to increase the number of individuals from underrepresented groups in medicine. Thank you, Dr. Azobou, for coming in here today. As always, CME credits are available, and the slide is up here. Without further delay, yours.
Thank you, Vaishnavi, for the great introduction. And thank you, Dr. Tonleu, for inviting me to give this talk today. And obviously, thank you, Dr. Mehta, for so many reasons. So today I'm going to be doing my presentation on ApoA is a big problem in coronary artery disease. Is it time for a name change? And so just reviewing the outline, we're going to talk about the structure of ApoA and the pathophysiology. We're going to talk about the evidence of association between ApoA and the risk of ASCVD. We're going to look at the prevalence of high ApoA as well as some of the guideline recommendations for testing. And then we're going to look at the prevalence of ApoA testing and some of the challenges associated with it, as well as challenges associated with interpreting the results. And then we're going to look at the therapies that lower ApoA, both current and emergent. And finally, we're going to discuss a framework on how to approach people with high ApoA, both in primary and secondary prevention. So let's start with the case. This is the patient that I saw in prevention clinic with Dr. Chiara a few months ago, Mr. LPA, he's 45-year-old. And he was admitted with a STEMI and had a stent placed to his mid-RCA. He denies any symptoms. He's been adherent to his antiplatelet therapy and he's starting rehab in about a week. For medication, he's on rosuvastatin, prasugrel, aspirin, metoprolol, as well as lisinopril. His father had an MI at the age of 50, and on social history, he denies alcohol, tobacco use. He works as a computer analyst, married with 3 kids, and went 3 to 4 times a week. His exam was pretty unremarkable. Blood pressure was controlled, systolic at 120. And then on labs, his A1C was 5.7, his LDL of 42, triglyceride of 68, and his ApoA came back at 300 nanomole per liter. And his TTE was pretty unremarkable. So before the end of the visit, he says, I read about ApoA online and it sounds bad. Given that my levels are elevated, what does it mean and what can I do about it? So we're going to start with, like I said, reviewing the structure and pathophysiology. But before even going there, I wanted to introduce the concept that's been in the literature for many decades, which is the concept of residual cardiovascular risk. And I think to understand this concept, it's good to look at this trial. This is one of the biggest trials in the world of lipid. This was the Fourier trial, where they randomized about 27,000 patients to placebo versus evolocumab. And they found a few things. One, they found that evolocumab reduced LDL by about 59%. But most importantly, they found that it reduced the risk of MIS events by 15%. Now, another way to look at this trial is with the following figure. Which is, despite the treatment group achieving a median LDL of 30%, there was still a 13% risk of MIS at 3 years. And this begs the question, what is driving that risk? And that's essentially what the residual cardiovascular risk is. It's the risk of cardiovascular events that persist despite achievement of targets for risk factors such as LDL, blood pressure, and glycemia. And the question is, what drives this risk? And back in 2018, Dr. Pandy and Dr. DeLemos out of UT Southwestern published this paper that identifies some of the risk targets driving this that range from lipoprotein, inflammation, metabolism, platelet, and coagulation. In blue are the therapies that have been found to reduce MIS event, and in green are therapies that have not yet been found to reduce MIS event. It should be noticed a lot of things have changed since then. We now know from the REDUCE trial that omega-3 fatty acid do reduce MIS events. And we know from the LODOCO-2 trial that colchicine also reduce MIS events. The other therapy that's not included here is bempedoic acid, which we know from the CLEAR outcome trials that as well reduce MIS event. For this presentation, obviously, I'm going to be focusing on lipoprotein specifically. And before discussing the structure of ApoA, I wanted to take us back to general chemistry 101 and look at what actually is lipoprotein. And essentially what it is, it's made of a lipid core of triglyceride and free cholesterol surrounded by an outer shell of phospholipids. And we have three major lipoproteins, HDL, LDL, and lipoprotein A. HDL use apolipoprotein A, which actually reduces the amount of lipids in the blood and has been found to lower ASCVD, while ApoB100, as we all know, is associated with a higher risk of ASCVD. Now, the one difference between lipoprotein A and LDL has to do with this glycoprotein. And zooming a little bit on ApoA, what we find was it has this ApoA glycoprotein that's synthesized in the liver. It's made of 10 subtypes of Kringle domain 4, 1 Kringle domain 5, and this protease domain that you can see in the bottom right. Kringle domain 4 subtype 2 is actually very important, as we'll see in the next couple of slides. It can expand into over 40 identical copies, and we'll see why that matters in a little bit. We have this protease domain that is inactive, and it's very similar to plasminogen. And that's been found to actually increase the risk of ASCVD, as we'll see in the next slide. And finally, a very important structure of ApoA is this Kringle domain 4 subtype 10. And this is a site of attachment for oxidized phospholipids, which can promote inflammation. Now, the question becomes, how does ApoA actually lead to increased ASCVD? And it does it in three ways. And this is a picture from a paper published by Anurag Mehta in the audience. And I think it shows all those three structures very well, starting with ApoB. This is similar to the way that LDL leads to increased ASCVD, which is through oxidation and foam cells. Now, ApoA does have this lysine binding site that enhances binding endothelium. And I will see in the next slide, because of that, it might make it more atherogenic than LDL. The second mechanism that it used to increase ASCVD is through inflammation. Like I mentioned in the prior slide, this Kringle domain 4 subtype 10 can attach to oxidized phospholipid, and it has actually been found to carry up to 90% of all oxidized phospholipid in the blood. And the reason why that matters is these tend to promote secretion of cytokines, migration of monocyte, and upregulation of adhesion molecule. And that leads to inflammation, which, as we all know, leads to an increased risk of ASCVD. And the last part is has to do with thrombosis. Like I said, he does have this protease-like domain similar to plasminogen, but it's inactive. And so this can lead to decreased plasminogen activation and impaired fibrinolysis. I wanted to share this paper. This is a paper that was actually published earlier this year. This was a paper looking at the genome-wide association of the UK biobank population. It's the largest population with ApoA to date, and it's about over 500,000 people. And they essentially identified two single nucleotide polymorphism, one linked to LDL and one linked to ApoA. And what they wanted to do is to look at the relationship of variation in ApoB and coronary heart disease. And as you can see, when comparing the ApoA cluster to the LDL cluster, there was an increased risk in coronary heart disease with the ApoA cluster. And what they actually concluded was, though LDL particles are much more important than ApoA and carry a greater proportion of overall risk, on a per particle basis, ApoA is actually 6 times more atherogenic than LDL. So we know what ApoA is. We know how it causes increased ASCVD. The question becomes, what drives the concentration of ApoA? And it seems to be mostly genetic through this LPA gene. So ApoA has been found to be 90% genetically determined. It is actually the lipoprotein with the stronger genetic control. It is inherited in autosomal codominant fashion, and adult levels are actually reached by 5 years of age. And the way it does so is by coding for finger domain 4 and 5. And we know from this paper that was published back in 2014, kind of the relationship between the gene and the concentration. So what they did in this paper, this was out of a cohort from Germany, over 6,000 people, and they looked at the distribution of ApoA concentration, and they stratified the median concentration by the number of finger domain 4 repeats, as well as genotype of this single nucleotide polymorphism. And what you can see is a lower number of repeats using a cutoff of about 22, you had a higher median ApoA concentration, and the converse was true. So it was lower at higher number of repeats. And I think the reason why this is happening is because higher number of repeats lead to a bigger ApoA molecule, which makes it more likely to be degraded in the cell. And so we now know, and actually in many studies, we've used the number of repeats as a surrogate for ApoA concentration. Now that we talked about it, we can move on to the association with ApoA and increased ASCVD. And really, one of the landmark studies in this space was published back in 2008. This was the Copenhagen City Heart Study. This was over 9,000 patients that were enrolled from 1991 to 1994. And so they had about a 10-year follow-up. And so on the left, they adjusted for age, and on the right, they adjusted for age as well as multiple risk factors. And what they found was, when adjusting for age, there was an increased risk of both MI and ischemic heart disease. And that increase was thought to be significant about the 90th percentile, which was the 85 to 190 milligram per deciliter. Now, if you adjusted for age as well as multiple risk factor, that significant increase was actually seen as the 67th percentile, which was the 30 to 84 milligram per deciliter. Another finding from this paper was, if you compare people with very high level, this is the 95th percentile above 120 milligram per deciliter, to people less than 5 milligram per deciliter, that was about the 22nd percentile, they found a 4-fold increase in relative risk and 35% higher absolute 10-year MI risk. The other thing we've learned from ApoA and the ASCVD risk comes from the UK Biobank. This is a cohort of 500,000 people, aged 40 to 69, that were enrolled between 2006 and 2010, with a median follow-up of 11 years. And what we learned from this study is that the risk of ASCVD appears to be linear. And so at a higher ApoA level, you have kind of this constant increase in level. But more importantly, at least I thought was most important was, it doesn't just matter what your baseline risk is, it also seems like your risk, your lifetime risk over time seems to be exponential. So whenever looking at a patient with high ApoA, it's not about what the risk is today, it's also, we have to think about 10 years, 20 years, 30 years down the road. Now, the UK Biobank and the Copenhagen City Heart Study taught us a lot about ApoA. The biggest limitation with it is they were not very diverse. These were people from European cohort. The UK Biobank was actually 94% white. And so the question becomes, do you see this risk as well in a more diverse cohort? And the answer is yes. This is the largest study. This was the first large study looking at ApoA and the risk of coronary heart disease. This used the MESA cohort, which is the multi-ethnic study of atherosclerosis. This patient was about 6,000 that were enrolled between 2000 and 2002. And we learned a few things from this paper. The first one being, it seems like Blacks have 3 times a higher median ApoA, which was like 35 compared to Caucasian, Hispanic, and Chinese. However, when they adjusted for multiple risk factor and looked at the risk of coronary heart disease in this very diverse cohort, there was still a significant increase with a hazard ratio of 1.26. When they looked at individual risk group, Blacks and Caucasian also had an increased risk, but this was not seen among Chinese, American, or Hispanics. Another paper that actually was published this year looked at the same thing, but it was a much bigger study. And essentially, they looked at ApoA and ASCVD outcome in 27,000 patients without ASCVD from 5 prospective studies. This included MESA, Cardia, Jackson Heart, Framingham Offspring, and ARIC. And so what they did is they looked at ApoA level and they classified based on the cohort-specific percentile. And what they found here was you start to see an increase at the 50th percentile, but really it became steep at the 75th percentile. And so when they look at the hazard ratio, adjusting for multiple risk factor, in the overall cohort, they found that you start to see a significant increase in ASCVD at the 75th percentile. Now, if you looked at individual race group, among white, it was also 75th percentile. Among Black, actually, it did not become significant until you got to the 90th percentile. And interestingly, similar to the prior study, they saw no significant increase among Hispanic or Asian American. Now, for the next 2 people I'm going to talk about tells us about the interaction between ApoA and family history, as well as ApoA and coronary artery calcium. And both of them are actually papers that were published by Anurag Mehta in the audience. In the first one, he wanted to look at the independent and joint association between ApoA and family history with ASCVD and coronary heart disease among asymptomatic subjects. So he looked at the ARIC cohort, which was about 12,000 patients and 21-year follow-up. And he defined elevated ApoA as the highest risk specific quantile. And using the control of non-elevated ApoA and no family history of heart disease, he found that both family history and ApoA were independently associated with increased ASCVD, but the highest risk actually was seen when you had both of them. So this suggests that using family history will be helpful to stratify a patient who have high ApoA to help define the risk better. Now, in the second paper that he published 2 years after, looked at the interaction between ApoA and calcium score. And for this one, used the MESA study and then replicated it in the Dallas Heart study. And similar to the prior, defined elevated ApoA as the highest quantile. And then he broke the calcium score into 3 categories, 0, 1 to 99, and above 100. And as you will expect, people who had high ApoA and high calcium score had the highest cumulative ASCVD risk, followed by people with high calcium score and a non-elevated ApoA. To me, what I found was most interesting was if you compare the control, which is non-elevated ApoA and a calcium score of 0, you find that those people who had elevated ApoA and calcium score of 0 did not have an increased risk of ASCVD. And so this statement coming straight out of the paper was elevated ApoA and calcium score are independently associated with atherosclerotic risk. Patients with both are at a higher risk, but it seems like the ApoA levels does not further stratify risk among people who have a CAC of 0. And so this suggests that if you ever get a patient with a high ApoA, getting a calcium score could help you decide if anything needs to be done from a therapy standpoint. And before moving on to the next session, I wanted to talk about the cutoff, because we've talked about multiple papers and there are other papers that try to look in terms of when does your risk become high. And though we have the number in the guidelines, based on these studies, it's actually quite unclear. In the MESA, it was stored. It was 60
Yeah,
milligrams.
it goes off regardless if I take it out. So well, can I just show you all the stuff that I have? Like,
All right. Can anybody hear me now?
thank you.
You okay? I think it's okay. So in the MESA, the cutoff was 50 among Chinese, Hispanic, and white American, while it was 30 among African American. In the UK Biobank, it was 150 nanomole, or race-specific 90th percentile. In the Jupiter trial, this was the rosuvastatin trial, it was 50 milligram, and in the STAT meta-analysis, it was 30 in placebo and 50 in statin-treated patients. And I think this kind of, raises a couple of questions. Should we be using absolute or should we be using percentile? Should it be risk specific? And then should it depend on the primary versus secondary prevention? And I don't know that we have answers to this yet, but hopefully over the next few years, as we learn more, we should be able to answer them. So now we're going to talk about the prevalence in L-PRO-A and the guideline recommendation for testing. These two figures are from the UK Biobank, which I've already talked about, but just as a reminder, this was 500,000 people recruited between 2006 and 2010. And of those, 460,000 had L-PRO-A checked. And they wanted to look at the prevalence of L-PRO-A. Now they use a cutoff of 150. The guidelines currently use 125. And so it's not necessarily the most accurate. But they did want to separate the primary prevention from the secondary prevention. So looking at people without history of ASCVD, about 12% had what's considered elevated L-PRO-A. And if you look at those who had ASCVD, that number went up to 20%. Now, this study, the L-PRO-A heritage study, is helpful to me because I think it shows kind of the impact of targeted L-PRO-A testing. And so they were looking to have the prevalence of elevated L-PRO-A in patients with history of ASCVD with the goal to identify patients suitable for L-PRO-A horizon. And what this is it's an ongoing phase 3 trial that's looking at the effect of pilocarsen, which is a L-PRO-A therapy, on ASCVD outcome among people with high L-PRO-A. And so they looked at people who had history of MI, ischemic CVA, and PAD. They recruited from almost 1,000 sites between April 2019 and July 2021. They were able to recruit about 48,000 patients. And in this study, using the same cutoff of 150 nanomole, they actually found that the prevalence is 26%. And to me, this shows that if we are intentional about who we check L-PRO-A on, we might actually find that the prevalence is much higher than we think. And between this study, the prior study, among other, we've learned a few things about L-PRO-A distribution. It seems to be rightward skewed with over 1,000-fold range. It's estimated that about 20 to 25% of the population have elevated L-PRO-A. That is 64 million people in the US and 1.4 billion people worldwide. And this slide kind of shows that this is a problem worldwide, not just in the US. And as a matter of fact, if you look closely, you actually see that the prevalence is highest in Africa at 30%. And I think this might explain why the median L-PRO-A among Blacks in the US is so much higher, likely due to the genetics that has come out of there. Now, turning to guidelines, we're going to look at 3 major guidelines. The first one came out in 2018. This was the AHA-ACC cholesterol guidelines. They recommended testing in people with a family history of premature ASCVD, people for risk enhancement primary prevention. So these are your people at intermediate risk, and you're trying to decide if they should be on a statin. People who have had ASCVD, but they don't have any typical risk factor. And they define high as above 50 milligram or 125 nanomole per liter. Now, the 2019 ESC and European Atherosclerosis Society guidelines, they actually recommended at least once in everybody. They had a similar cutoff for elevated. They actually recommended screening for FH in people who have level above 180 milligram per deciliter because these people have a similar ASCVD risk than people with FH. And in 2022, the European Atherosclerosis Society released a statement recommending cascade screening in family members. And then finally, the 2019 National Lipid Association scientific statement, they actually released a focus update earlier this year where they actually switched from ACC to ESC, where now they're recommending it at least one in everybody as a risk enhancer in primary prevention, and they're also now recommending cascade screening. And similar to the other society, they had a cutoff of 50 milligram per deciliter or 125 nanomole per liter. Now, we're going to turn your attention to the prevalence of testing. We talked about, and then some of the challenges with it, and also the challenges with us interpreting the result. So, to no surprise to anyone in the room, testing for APRIL-A is actually quite low. And one of the first papers to look at this was published last year in 2023, and they looked at 6 academic medical centers. This was over 5.5 million people with a CVD diagnosis from 2012 to 2021. And what they found was only 0.3% of all adults underwent APRIL-A testing. It was 3% of people with family history of coronary vascular disease and less than 4% with history of CVD. And if you look on the bottom right, the testing went up slightly around 2015, but it's kind of remained stagnant since then. And when looking at people who underwent APRIL-A testing, they were more likely to be older age, male, white, higher prevalence of CVD condition, on statin therapy, and ApoB, have undergone ApoB testing. Another paper that tried to answer this question was also published last year, and this was an observational study that looked at patients from 11 US health systems from January 2015 to December 2019. They looked at over 100,000 patients, and they compared 2 cohorts, people who had undergone APRIL-A testing and those who had undergone LDL without APRIL-A testing. And they found that APRIL-A testing was about 0.06% of patients per year. When they compared the APRIL-A cohort to the LDL cohort, they were more likely to be male, have hypertension, hyperlipidemia, prior ASCVD, and APRIL-A testing was more likely to have occurred in patients than LDL. In the heritage study that I mentioned previously, they actually had a testing rate there of 14%. But there's obviously bias in that study because they were reaching out specifically to academic centers that are more likely to check APRIL-A. Now the question becomes, what is being done about it? Actually, I've been working with Dr. Kara and Dr. Joshi at UT Southwestern to try and see if we can increase testing for APRIL-A. And our pilot study actually is focusing specifically in cardiac rehab. And so the goal is to enrich the high APRIL-A population by focusing on patients referred to cardiac rehab. We are planning to recruit 100 patients, recruit to cardiac rehab for either ASCVD, valvular heart disease, or heart failure. We'll be collecting APRIL-A, lipid panel, ApoB, and lipid-lowering prescription at baseline, and then 12 weeks later. And our hypothesis is that the prevalence of elevated APRIL-A using a cutoff of 125 nanomole per liter in cardiac rehab is higher than the secondary prevention general population. We also are expecting that there will be no difference in lipid-lowering prescription and LDL at 12 weeks between patients with normal and elevated APRIL-A. And then finally, we're expecting a higher median level with ASCVD compared to valvular heart disease and congestive heart failure. Now, let's discuss some of the challenges associated as to why we are not checking APRIL-A. One, there's obviously lack of awareness regarding APRIL-A and some of the guideline indication for testing. Two, there used to be an insurance coverage. Prior to 2018, there was variable reimbursement because there was no diagnostic code for APRIL-A. Three, and I think for a lot of physicians, this might be the most important, is we don't have any APRIL-A specific therapy, and we really don't have any data that prove that reducing APRIL-A will lead to a reduction in MACE. Another issue has to do with the lack of standardized measurement assay. I've kind of gone back and forth a lot between milligram per deciliter and nanomole per liter. And essentially, there's 2 ways to measure APRIL-A. The one that's more widely used, and it's because it's more widely available and less expensive, is mass in milligram per deciliter. And this uses polyclonal antibodies. The issue with this is it's isoform dependent, which means based on the size of ApoA, it can either underestimate or overestimate the ApoA concentration. There's a ratio that's being used, which is to multiply the mass in milligram per deciliter to 2.5 to get a nmol per liter, but that has significant limitation and it's really not recommended. The gold standard by the major society has been to use nanomole per liter. There you measure the particle number. It uses monoclonal antibodies. It is more complex, but it is more expensive. And so now I want to kind of switch a little bit to the challenges with what happens when you get the result and how to actually interpret it. And I think one major one that I've kind of talked about already has to do with the heterogeneity based on race and gender. This is from the Dallas Hall study, where they found, similar to MESA among many other cohorts, that Blacks had higher median level than white and Hispanic. And in the RX study, women actually had level 5 to 10% higher than men. Now, it should be noted is even though they have different median, if you look at the proportional increase in ASCVD, it's the same for all of them. But this again does beg the question, should we have a different threshold based on race and gender? Another challenge with the absolute risk threshold is it has been found that there's actually significant variability within the genetic context. In the phase 2 trial of pelacarsen, the ApoA therapy, when they measure serial blood sample in the placebo group, they found that the value could change by as much as 25%. And one of the ways they explained it was it could be to diet, hormonal, or inflammatory etiologies. And actually many things have been found to have an effect on ApoA. Pregnancy, nephrotic syndrome, hypothyroidism, and IL-6 have been found to raise ApoA, and postmenopausal hormonal replacement therapy and low-carb, high-fat diet has been found to lower ApoA. So next, we're going to look at some of the therapies that lower ApoA, both current and emergent. And I wanted to start with statins because I think this is the most interesting. So this was a meta-analysis of over 5,000 patients from 6 RCTs. And what they found was the mean percent change from baseline in the statin group was from 8.5% to almost 20%, compared to the placebo where it was negative 0.4% to negative 2.3%. And so there is a concern that statin could actually be associated with an increased level in ApoA. Now, that being said, in a larger meta-analysis of over 24,000 patients, they found that there was no change in the ApoA-associated ASCVD risk. So even though you have high level of ApoA with statin, your risk of ASCVD does not go up. Next, I want to look at PCSK9, and this has actually been found to lower ApoA level by about 25%. This figure is specifically for the Fourier trial, where they found that it reduced ApoA, evolocumab reduced ApoA by about 27% at 12 months. What was most interesting was when they looked at people who had ApoA below the median, there was no MACE benefit with evolocumab. But if you look at those who had ApoA level above the median, you find a 23% reduction in MACE outcomes. When instead of using the median, they used the cutoff of 120, essentially looking at people who had either high ApoA or non-elevated ApoA. You see that among people who had non-elevated ApoA, there was no benefit with evolocumab, but among those who had high ApoA, you saw a 25% reduction in MACE outcome. The one on the right is looking at alirocumab, and this is from the Odyssey trial, where they found a 23% reduction in ApoA at 4 months. When they broke it down in 2 quartiles based on the ApoA level, you can see that the MACE reduction benefit with alirocumab was higher with higher ApoA. And what we actually learned from this was there is greater ApoA and MACE reduction independent of cholesterol at higher ApoA level. Next, I want to look at the lipoprotein apheresis, which has been found to reduce ApoA by 25 to 40%. And we know this because of the German apheresis registry, where they looked at over 1,200 patients with cardiovascular disease undergoing ApoA apheresis for high LDL and or high ApoA. And what they found was there was a 70% reduction in ApoA acutely. And when the time average between session, it was down to 35% reduction. And because of this and other study, FDA, this is actually the only FDA-approved therapy for elevated ApoA. Now, there are some challenges with it, including weekly and biweekly sessions that can last up to 2 to 3 hours. There is a scarce availability of centers. Cost obviously is an issue. And then there's some complications such as bleeding and AV fistula. There is a trial, the multi-select trial, that is looking at the missed effect of weekly lipoprotein apheresis with maximally tolerated lipoprotein therapy in patients with high ApoA and LDL less than 100. The next class of therapy I'm going to discuss are called antisense oligonucleotide. And essentially, these are single strand with a GalNAc that helps it to bind to the liver. And then once inside the liver, they can bind to the targeted mRNA, forming an mRNA antisense complex. And then what happens next is the RNase H separates the antisense from the mRNA, which undergoes degradation. The anti-strand is now free to bind to another mRNA antisense complex, which leads to a longer half-life. And the phase 2 trial looking at this therapy was published back in 2020. This therapy is called pelacarsen, and they randomized 286 patients with ASCVD and high ApoA. And what they found was there was an 80% reduction in ApoA. And at the highest dose regimen, 98% reached a level less than 125 nanomole. There is an ongoing trial, the ApoA Horizon, that randomized patients with ASCVD and ApoA level above 70 milligram per deciliter. They actually finished enrollment in July of 2022. And so hopefully either ACC or AHA of last year, we should be getting results from this trial. The second class of emerging therapy in this space is the small interfering RNAs. And essentially similar to the antisense oligonucleotide, they use GalNAc to bind to the liver, but these are double-stranded. And once inside the liver, they form a complex with the RNA-induced silencing complex. And that leads to the cleavage of the target mRNA. And so that leads to the reduction in synthesis of the protein. And the phase 2 trial here was published in 2022, and it looked at the effect of olpasiran in 281 patients with ASCVD and high ApoA. And in 3 out of the 4 doses, they found 98% achieved ApoA less than 125. The Ocean Outcome trial, that's the phase 3 trial for this therapy, is looking at patients with ASCVD and ApoA level above 200 nanomole. And we're probably expecting results for this in 2026. Now, both of these therapy had issue. The only side effect was injection site reaction, which was actually higher with the pelacarsen than it was with olpasiran. And these are kind of the other therapies in the pipeline. We talked about the first 2, but then there's also 3 more currently undergoing phase 1 trial, and we should be hearing about them very soon. Now, something that I found very interesting that I wanted to bring up is the idea that very low ApoA level have been associated with incidence of type 2 diabetes. This is, again, to the Odyssey trial. In this study, they wanted to look at the relationship of ApoA concentration and the incidence of diabetes and the effect of alirocumab. Now, they found that there was no overall effect with alirocumab on the incidence of diabetes. But when they look at patients with ApoA less than 50, the incidence of diabetes with alirocumab was higher, but it was higher in those with ApoA above 50 milligrams compared to placebo. And there was actually a subsequent meta-analysis that looked at the risk of diabetes between the top quintile and the bottom quintile. And they actually found that there was a 38% increase in incidence of diabetes. As we know, there's also been shown with LDL that low level can lead to an incidence of diabetes as well. So I think it's interesting to see what this goes in the next few years. And so now I want to spend kind of the rest of the time talking about now the approach to ApoA testing and kind of a framework to it based on what I learned. So I kind of broke this into two, kind of like a class 1 and class 2A. So for tier 1, I think using it as a risk enhancer for the people you're trying to get started on statin, I think anyone who has premature ASCVD, you had that tested, anyone who has ASCVD with atypical risk factor, and anyone with suspected FH. Tier 2 is family history of premature ASCVD, if they have LDL above 190, and then that's also where I will put the cascade family screening. Now, I did not include universal screening on this. I actually had a very long conversation with Dr. Kara about it, and so we can definitely talk about it in the Q&A. And then for testing and threshold, I think we should be using the nanomole per liter because we know it's the most accurate. I think we should consider elevated anywhere from 100 to 125 nanomole per liter. And since we know that having an AKI, liver injury, or ongoing inflammation can affect the ApoA level, I think for the people in who it's really going to make the difference, so the tier 1 people, if it comes back, you should probably repeat it before deciding what to do next. And then finally, looking at the management of high ApoA in primary and secondary prevention. So for primary prevention, I think lifestyle modification. I think if they have a family history of premature ASCVD or CAC above 0, we should start a statin. I think we should start aspirin if CAC is above 100. We should screen first degree relative and screen for FH if it's above 400 nanomole per liter. Now for secondary prevention, aggressive risk factor modification. Early initiation of PCSK9, actually Dr. Kara suggests that you can consider actually lowering the statin just so you can add a PCSK9 if you're running interference because of the LDL, which I think is a very interesting take. We should consider lipid apheresis based on the data. Again, screen first degree relative and screen for FH. So going back to the case, what will I do for this patient? One, obviously address and optimize any cardiovascular risk factor. I do think cascade screening for family member, children, and siblings. And I think you should consider PCSK9 and lipoprotein apheresis if recurrence of ASCVD, regardless of what his LDL is. So some of my takeaway point from the talk, ApoA is associated with an increased risk of ASCVD. Elevated ApoA is prevalent, but testing has been low. PCSK9 and lipoprotein apheresis can lower ApoA level. I think ApoA should be tested in patients with premature ASCVD, those at intermediate risk of ASCVD, and those with ASCVD with that typical risk factor. And finally, there are ongoing clinical trials evaluating the effect of ApoA reduction on CV outcomes. And I wanted to thank Dr. Kara and Dr. Joshi. They are prevention cardiologists at UT Southwestern. Dr. Peterson and Dr. Bat, those are my PD and APD. And obviously Dr. Hunley for inviting me to speak, and Dr. Mehta for getting me to UT Southwestern. Any question?
Got a quick question. You mentioned modifying risk factors. That was kind of number one. What risk factors do you modify and how do you implement that?
Yeah, I think maybe the only thing I would consider, for the case that we had, everything was pretty optimized from a lifestyle standpoint. Okay. And so I think very often the challenge of these people, especially your early ASCVD, is that the risk factors have been optimized. And so very often with them, the question is, do you just need to add additional therapy? But I think we know obesity can lead to a higher risk factor. And so if they had a higher BMI, you can chase that. I think something to consider is we know inflammation causes a problem. So do you check CRP? And based on CRP, do you decide, oh, let me add colchicine to look at inflammation? So I think those are probably the things I would start first. But it's very challenging because for some of these patients, they're already doing all the right thing from the diet and the exercise standpoint. And there's really nothing else that you can add.
One question. Excellent talk. You mentioned something that is well established with LP little a and African American patients having, on average, higher levels. We also know that there is race, ethnicity-based disparity in terms of ASCVD risk and poor outcomes. You think that this could be, high LP little a could be a contributing factor to the disparities that we see pretty much every day all across the country? And is there a role for more intensive LP little a testing in our African American patients? Because your chances of finding that?
Yeah, I think that's a great question. I think as we saw, to your point, the median LP was higher. The one thing was, even though they had higher median, you didn't start to see a higher increased risk at a higher level. And so to me, it makes it difficult to say, oh, the high LP is the reason why. Obviously, we know this is all multifactorial, but I do think it's too soon to know. I think hopefully with things like LP Horizon and Ocean outcomes, if we can get more of them on those therapies and see what outcome it has on the population level in terms of reducing the overall complication of cardiovascular disease, I think that would be helpful. But I think the reason why I wouldn't necessarily attribute it to it is because for them specifically, even though they have higher level than everyone else, the risk of ASCVD also seems to be happening at a higher level. So it seems like the baseline is shift and the ASCVD risk is shift. So I don't know that I will say LPRO-A is driving it.
Thank you, Dr. Azobou. That was a great answer.
Oh, I think she had.
Hi, I have a question.
Sorry.
Okay, great presentation. It was interesting that I think from one of Dr. Mehta's papers, he said having a CAC score of 0 and having a high LPA, your risk is actually 0. I mean, you have a lower risk as long as your CAC score is 0.
Yes.
So is it reasonable then, given that we don't have universal testing, and right now when you test, you actually get like a copay? I had to get a copay when I checked my LPA here. If getting a CAT score is cheaper, do you think it's reasonable to just then get a CAT score for somebody, and if it's 0, maybe I don't have to check LPA now and wait later when it's more affordable and universal?
I think that's a really good question. I think cost definitely should be a factor. I think the thing with the LPRO-A level is that even though a calcium score and high LPRO-A level does not mean you're high risk, it does speak to your long-term risk. And so we're not just looking at your risk today, we're looking at your risk 10 years, 20 years, 39 years down the road. Now, for someone who's young, who has no risk factor, who's like almost doing it kind of like as a screening tool, I don't know that it matters as much now, but for someone who had an event, for someone who has intermediate risk, I think even with the CAC of 0, I still want to know if the LPRO-A is high. Now, as to whether I'm going to be doing anything about it anytime soon, I think that's the question.
Also, that paper was limited in the sense that the follow-up was 10 years. So it wasn't for a 25, 30 year, which becomes very important for a young patient. And I can speak, I guess, don't know about other places, but in Virginia, LP-little-A is also available as a direct-to-consumer test for $49 through LabCorp. So if anybody is interested in, avoiding unknown copays, that's an option.
I guess you mean without a prescription for a physician?
That's right.
They can just go and get it?
Yes.
And your thoughts on it?
My thoughts, I mean, if you want to know and you want to avoid any kind of unexpected copays, $49, if you're able to afford it, then I think it's worth getting it. I have friends, patients who've had it done, which kind of puts into perspective. For example, CAC score is $99 out of pocket at VCU. Our competitors offer it at, I think, $130 or $150. So if you're thinking about price, that's where we are. That's where we are here in Richmond and Virginia.
I think it's very interesting because it brings the question, like I said, that I had with Dr. Kara, which is universal screening for LPRO-A. And he and I actually sit on different fences. He's for and I'm against. And partly because I don't think we know enough about it yet. I think you see that ACC, they have booths and everybody's like, I want to know. But yes, we know your level was high, but I don't know that we know enough to be like, oh, everybody get it. Because if, let's say, you check it and yours comes back elevated, you come to my office, it's like, what do we do next? I'm not going to tell you anything different that I wasn't going to tell you before the test, which is eat better, exercise, if you have high blood pressure, less. So I think it's an important test now as to whether, but I don't think it's reached the level of calcium score where I'm like, hey, I'm fine if you just want to go get it just to know, because I just don't know that we know what to do with it yet. Now the flip side to that has to do with Dr. Kara got a physician will reach out to him about a 32-year-old woman who had a massive MI and her LPA level came back like 500. Now, if she had known beforehand, will you have made a difference if she's already doing all the right thing? I don't know. Is it good to know? Maybe. But again, the question is not just what you know, it's what can you do about it? So that's kind of personally, I don't think universal screening is the way to go yet. But I can see the argument for it.
I have a question.
Mhm.
So if there is a like the subset of patients who have like chronic inflammatory diseases,
Mhm.
things like that,
Mhm.
is there any utility for like treatment of LPA regardless of ASCVD score or not really?
I don't think as of right now we have that data. Again, as of right now, we know LPA within a context of atherosclerosis disease. And actually, it's not just coronary, it's also PAD, it's also stroke, actually valvular disease and heart failure. So we are in the very early stages. And so to me, I think we have to start focus in the highest risk. And so I would probably start in the secondary prevention cohort, kind of your young patient. And then as we know more, we can look into other population. But I think it's just it's very early. And it's also, in a way, very risky to make it broad if you don't know enough. Because if I check your level and it comes back high, now you're going to be anxious because you're like, what's going to happen? And I just don't know that I have a way to be like, I think this is what's going to happen because we just don't know at this time.
I have two quick questions.
Mhm.
You
Sorry,
mentioned
I have
a lot
a
of variable
question.
factors that could affect the LPA. Then I wonder if LPA is more like a glucose thing or more like A1C thing. Doesn't matter if the patient eats or not when they get tested.
Okay.
Then how long will we be testing again after the patient has lifestyle modification, like 3 months or 6 months or things like that? My question number two is, you mentioned PCSK9 inhibitor is indicated regardless of whether LDL is in target or not.
Mhm.
Based on your experience, do you think it's an issue whether insurance is going to cover it or not?
Yeah. I think going to the first question, as we know from the presentation, is genes drive it. And so even though it's going to change, it's not going to be very, very different. Now, in someone who's having AKI, they're in the hospital for pneumonia, a very high inflammatory state, or they're pregnant. In that patient, if for whatever reason we check, you probably want to wait until they are more stable. So if they were having an infection, you wait until they clear the infection. If it was pregnancy, you wait postpartum and then you check again. Because I think that's probably when I would check it. Now, regarding the PCSK9, at least at UT Southwestern, and I asked this to Dr. Kara, you don't have to prove a certain LDL cutoff to start PCSK9. You see, you just have to write in the note LDL is not that goal. You get to decide what the goal is. Now, this could be different at different places. Some other insurance company might say, if you had an LDL of 50, I'm not going to approve PCSK9 because you had goal. And so I think it's probably going to be very dependent on the institution and the insurance. But at UT Southwestern, you can just put someone on the PCSK9.
The guest on Zoom that has a question. Go ahead.
Yeah. So I had a couple of questions. The first question is, what is the correlation of Lp(a) to plaque morphology? And the second one is, if we are treating Lp(a), has it shown to cause plaque regression? And, with techniques like AI techniques like clearly able to identify plaque morphology pretty accurately, are we able to use such AI techniques to be able to study the effects of treating patients with high Lp(a)?
Yeah, I think those are great questions. I think regarding the plaque issue, the only correlation that we have has to do with the oxidized phospholipid that I mentioned earlier, which leads to more inflammation. Now, as to whether we know PCSK9 lower the ApoA, and we know PCSK9 stabilize the plaque. Now, as to whether stabilize the plaque had to do with ApoA or that's completely separate, I don't think that we know yet. And I don't know, to my knowledge, I don't know if Anurag knows different, that we have any data assessing lowering ApoA on the plaque morphology or stability. I don't know. Anurag, do you know?
No, something maybe in the future, but
Yeah.
to my knowledge as well, there's
Okay.
no sub-studies
That's been done.
looking at that.
Okay.
Great
Thank you so
presentation.
much.
I was intrigued by one of the last slides that you put forth.
Mhm.
You talked about an increased incident diabetes with individuals that had lower LP little a values.
Mhm.
And then in a prior slide, you talked about carbohydrate and saturated fat
Mhm.
diet. I don't remember if it was high or low high was associated with low 15% lower. Has anybody looked at diet composition in these studies, and maybe that incident diabetes risk could be factored out when you look at maybe diet composition?
Yeah, I think that's a good question. I don't know, because that study that I mentioned, the first one looking at that correlation was from the PCSK9 study, the Odyssey trial. And I don't know that we have data regarding the diet. The thing I will say is that will be very difficult to do in terms of, we're talking about thousands of people, and then you might be doing survey, like what is your diet, rather than actively looking what the diet is on a daily basis. So I feel like it's a lot more difficult to prove. Now, there could be something to it. I just don't know.
Thank you.
Thank you.